Morning and welcome to our live breast cancer tumor board this morning. A special thanks to all of you for joining and to the doctors who are presenting our cases this morning. Firstly, we have Dr. Diego Toyo from Montevideo in Uruguay. And Diego, just raise your hand. Well, you'll see him in a minute. We have for the first time, and thank you very much for joining, we have Dr. Tara Solko from Lviv in the Ukraine, who's presenting our second case. Thank you. And Dr. Joel Marino from Panama City.
He's having technical difficulties, but he'll be joining us in a few minutes.
And Dr. Marino is going to be joining us soon. And also a very special welcome and thanks to our panelists from Boston and around the United States. I'd like to emphasize the usual housekeeping rule of please keeping your microphones on mute, which you're all doing. Thank you very much. Unless you want to speak, you just turn it on. And when it's on, if you speak, the camera should attract your voice and your face when you're speaking. As usual, all PowerPoint cases that are presented this morning will be archived on YouTube, as well as the discussion with a corresponding discussion of each case for archive for everybody to view afterwards if you want to, or for any of your trainees or any other doctors who want to see the tumor board. At the end of today's tumor board, I'd like to ask a special favor. If you wouldn't mind taking 5 minutes to take a selfie photograph of yourself or of all the people in your room, so we can start collecting pictures of everybody who attends the tumor board. We'd be very grateful if you send those to Jessica. So with that, I'd like to start by introducing Dr. Diego Toyo, and we'll project the first case now.
Hello, everyone. Thank you so much. Okay, we start.
Just give it a second.
Yeah.
That's Diego, very good-looking man, as you can see. Right, Diego,
okay.
Please go ahead. Yeah.
Yeah, this is a woman with 52 years old, postmenopausal woman, no family history of cancer, no comorbidities. In the last quarter of 2015, we did a mammogram. The mammogram showed articulate node left breast, viral 5. The fine needle aspiration was positive. The staging was negative, no metastasis. So she did a lumpectomy plus sentinel lymph node biopsy. The pathology informed that it's an invasive ductal carcinoma of 10 millimeters. The score was 8, grade 3, clear margin, sentinel lymph node negative, ER negative, PR negative, and HER2 negative 2. So in summary, okay, the question discussion. The first question is, we know, but in this case, if you recommend an oncotype.
Can we just handle the questions one at a time, Diego, if you don't mind?
Okay.
We just open the panel to that discussion. So the question from Montevideo, if I could just rephrase it, is in a patient who has a stage 1B, PN0 and M0 breast cancer, would an oncotype routinely be sent from your center or from your doctors? If anybody can answer that question, please go ahead.
This is Jack Urban. Yes, I believe. Can you hear me, Paul?
Thank you. We can. Thank you, Jack.
All right. Thank you. So I believe the first question would be, does she qualify for consideration for chemotherapy? The answer, yes. However, she's ER/PR negative, and the oncotype data have really been validated only for hormone receptor positive patients. So I don't think that the oncotype would be informative in a case like this. I think by virtue of her age, her grade, and her hormone receptors, I think a recommendation for chemotherapy could be given based on that alone.
So, Jack, what do you feel about a tumor that's a grade 3 tumor? Doesn't matter whether it's positive or negative ER/PR. What do you think about that for oncotype testing?
So that's a really great question, because in the original validation data, grade was actually a more important predictor of outcome than the oncotype score in multivariate analysis. So I tend to use a grade 3 alone as a indicator for treatment, and I don't send those out for Oncotype.
Does anybody want to agree or disagree with Jack? Any opinions, Brittany?
I would agree with that. I mean, I think you're looking at the tumor biology here, and the grade 3 or sometimes a really high Ki-67 can approximate that. There is some data. There's a small retrospective study done out of Hopkins that looked at predicting oncotype scores using just the IHCs, and you know, it was able to predict it with actually a good degree of accuracy.
So would you go on, Suzanne, just say whether you would send an oncotype on this patient or whether you would just recommend chemotherapy or not? Can you just give us your opinion, please?
I would recommend chemotherapy. I would not send oncotype.
Okay, if anybody disagrees or has something to add, can you speak up?
I have something to add. Sorry about my voice this morning. I'm getting over a cold. So yes, we would not send Oncotype, and we would give this patient chemotherapy because she has triple-negative breast cancer and has grade 3 disease. I do want to stress that we tend to only send Oncotype in patients that have hormone receptor positive and HER2 negative disease.
So then let me just get this clear for everybody. When you have a grade 3 tumor or a triple negative tumor, you're going to recommend chemo anyway, and you're not going to send the Oncotype, or a HER2 positive tumor. But can you tell us your size cutoff? If you've got a tumor that's HER2 positive, or a tumor that's triple negative, or a tumor that's just grade 3 or triple negative, whatever the biology is, grade 3, do you have a lower size cutoff?
Yeah, so I can comment on like the HER2 positive patients. Our size cutoff is 5 millimeters if they're HER2 positive, ER positive, and PR positive. And it's 3 millimeters if there's a hormone receptor negative and HER2 positive.
Okay.
And
so
the patients where we tend to send Oncotype are those patients that have T1C node negative and maybe high or intermediate grade, T2 N0 intermediate grade, and any patient with 1 to 3 positive nodes, which is low and intermediate grade.
Right. Did everybody get that? Are you satisfied, Diego, with that? So I think we've covered the Oncotype and the recommendation for chemotherapy. The general consensus is to give chemotherapy.
Mm-hmm.
Yeah.
And so your next question, Diego. You were asking about the regimen. What type of regimen of chemotherapy would this patient be recommended in terms of TC versus anthracycline followed by taxanes? So you want to know, in a patient with triple negative disease, and I'm just looking again, sorry, and 1 centimeter in size, what type of adjuvant chemotherapy would people recommend? Does anybody want to have a stab at that?
I think in the U.S. there's a great deal of controversy over this right now, and it probably won't get settled until we see the results of the NSABP B49 data. I think, and then that study is going to look at all of the different combinations of anthracycline and taxane, Taxol versus Taxotere, and non-anthracycline versus anthracycline regimens. That said, I think she would be eligible for either AC followed by Taxol. It's a perfectly acceptable regimen for a triple-negative breast cancer. But a lot of U.S. oncologists, I think, would be convinced and comfortable with the non-anthracycline regimen TC in this situation, discussing risks and benefits.
Roisin, are you there from Johns Hopkins? No, maybe Johns Hopkins wants to comment on this? Okay, I'm sorry.
Can you hear me now?
Yes, we can hear you, Roisin. Thank you.
So I do totally agree with what has been just said. I think for the triple-negative patients in general, I recommend the anthracycline-based treatment. but I think she would have been eligible for the Jones study of TC versus AC, if I remember correctly, and therefore I would probably discuss that as an option with her, and go through the side effect profile of each.
Brittany, can you comment?
Yeah, I thought in that study women were older than 65 when they were comparing TC and AC. And she's younger, so I would probably treat her with either ACT or TC would be appropriate. Regarding ACT, I think in this case we would tend to give dose-dense ACT, and I know that's not available in a lot of countries because Neulasta is not available. And so I think, the other option would be to give AC every 3 weeks and then give weekly Taxol for 12 cycles, not to give, every kind of 3 weeks Taxol, because there is...
Sorry, Brittany, just let me firm this up. Are you in favor as an alternative to give TC in this patient, a 1 centimeter triple negative tumor?
I think I would probably prefer giving her ACT.
Cesar, your opinion from Northwestern?
Sure, thank you. Yeah, I think it'd be a discussion with the patient, talking about the risks and benefits. Again, I think she would certainly be a candidate for ACT and may have a slight preference for that as well. But just because she has a smaller tumor to begin with, I think TC would be reasonable as well. I think it's a conversation to have with the patient, and if they want to do absolutely everything and be super aggressive, ACT might be more the way to go. But if they kind of really want to avoid chemo side effects or whatnot, TC would be reasonable as well.
And would you give dose-dense ACT, as Brittany was saying?
If it's available, as a standard, yeah, I would.
Okay, so I think that covers the next. So the only other question that...
Paul, Susan Sager, if I could interrupt here. So
Yeah.
the Jones study looking at the TC versus AC did accept premenopausal women. The youngest in that study, I just looked it up, was age 27. So I think it's a regimen we can use in young women. I personally would prefer TC, particularly if she has any cardiac risk factors, given that this is a very small tumor. Again, in the Jones study, I think it was about 25% of those patients were triple negative. So I think we have some data. So I think the question raised here is a good one, and I think the patient, speaking with the physician in charge of her care, can weigh side effects and decide what's best. But I think either regimen is acceptable.
Thank you, Susan. So
Thank you so much.
which I'd like all the medical oncologists to chime in if you can. What is the role of platinum analogs in triple negative adjuvant breast cancer chemotherapy? Can you just say whether you use it routinely or you don't, or sometimes you confine it to BRCA1/2 mutation carriers? Who, if ever, do you give platinums to with triple negative disease? Anybody can take that. Okay, Jack.
So I would not routinely use it in the adjuvant setting, with the exception being a well-documented BRCA1 or BRCA2 mutation, and then I would have a discussion with risk-benefit. I have used it as well in the same situation, neoadjuvant patients with BRCA, but I do not routinely use it for any other triple-negative patient.
Anybody else? Susan?
Yeah, so I would agree with Dr. Urban's comments. I don't know, Diego, what's available in Uruguay, but for this patient, we would, as any woman diagnosed with a triple-negative breast cancer, regardless of family history under the age of 60, we would recommend BRCA1 and 2 testing. So if that was available, I would certainly do that. If it's not available in the absence of history, I think you can guess maybe she's negative, but that may be helpful to do.
So Susan, would you just confirm that at MGH, the only patients we give platinums to are patients with confirmed BRCA1/2 carrier status?
Correct, and routinely only as part of a study.
Right, thank you. Okay, so I think that answers your questions, Diego. Thank you, that was a great case. The next case, this is the first time that they're joining from Ukraine. Taras Salko. Taras, would you like to go ahead when the slides appear and start presenting your case, please?
Okay, good evening. Can you hear me?
Yes, we can hear you, thank you.
Okay, we have 65-year menopausal woman with palpable breast tumor with no comorbidities. She came to us in 2014 with support in right breast, and we can see the 3 and 5 centimeter breast mass, upper lateral quadrant, and 2 ipsilateral mobile lymph node. CT and chest, we can see the same, 3 and 6 centimeter mass and axillary lymph nodes. Biopsy show invasive lobular carcinoma grade 2, ER3 plus, ER1 plus, and ERBAMU 1 plus. We made right mastectomy with radical axillary dissection, and histology shows the same, that it's infiltrated lobular carcinoma, and we found 14 metastases from 16 lymph nodes. After that, she got 6 cycles of adjuvant chemotherapy with endoxandoxorubicin fluorouracil. We have toxicities vomiting grade 3 and alopecia. Then she got radiation therapy, 40 grade to axilla, 40 grade to breast, 40 grade to supra and infraclavicular and parasternal area. We have diagnosis stage 3C right breast cancer. It's a mistake here. We have not T3, we have T2 and 3M0. And of the last, in 215, we make CT and found a lot of bone metastases in sternal, coccyx, mandibulum, and humeral head. We made a bone scan, osteoscintigraphy. It shows the same. We have a hyperfixation in all vertebral sternum, occipital bone, left graded trochanter and coccyx. She get a letrozole and zoledronic acid, and 1 month ago we find liver metastasis.
Taras, can I interrupt you? Before you ask your questions, as this is the first time you're presenting a case from Ukraine, and we're very grateful, I'd like anybody to just comment generally on this case, the presentation, the management, and everything. Can we just have an open discussion before we have specific questions? If that's okay with you, Taras.
Okay, yeah.
Thank you.
Yeah, I have a question about the radiation, because the doses used are not really standard. When you say 40 gray to the breast and 40 gray to the axilla, is it 40 gray in 4 weeks or in 3 weeks? I would assume it's in 3 weeks, like the British hypofractionation. Am I right?
No, it isn't hyperfractionation. We use it in 1. We get 2 gray every day from Monday to Friday, and she got 40 gray to the scar, to the right breast, and 40 gray to the axilla.
And what about the supraclavicular and parasternal? Is it 30 gray also in 2 gray per fraction?
On supraclavicular, we don't know exactly, but it is the same. Yeah, it's one area.
Yeah.
We use it in once.
What do you mean once? Like once?
It means that she got this 2 gray on the right breast and axil, and we include to this area supra and infraclavicular zone, because we have a lot of lymph nodes, and we can show and
So it's written here 30 gray. So you meant maybe 40 gray. So the whole chest wall and the regional lymph nodes received 40 gray and 2 gray per fraction, right? Am I right?
Yeah.
All right, just like a little comment. The only data in the literature, to my knowledge, which compared 50 gray versus less than 50 gray, is probably related to hypofractionation. I would probably, if you want to go with 2 gray per fraction, which is perfectly fine in her situation, but we usually go up till 50 gray and not 40 gray. I don't know if 40 gray is enough, especially for an aggressive tumor like that. And it seems to me that she developed metastasis rather quickly. I would guess that if she didn't develop this metastasis, or we are maybe 5 years out of her treatment, I mean, her risk of local failure might be a little higher. So we usually recommend 50 gray and 2 gray per fraction to the supraclav, to the axilla, to the IMC. 40 gray is a little in the low end.
Can we have some other comments about the radiation dose from other radiation oncologists? Does anybody want to comment?
Sure. This is Jean Wright from Johns Hopkins. I would just second what Dr. Tagian said. Unless you're using a hypofractionated regimen with a higher dose per fraction, I think these doses are definitely lower than what would be considered standard. I think that she did develop metastatic disease pretty early before, after her treatment, so probably it wouldn't have had a significant impact on this particular patient's outcome, but as far as her metastatic outcome, but I do think the dose is low.
Thank you. Just to go back a little bit, Dr. Gadd from MGH would like to make a surgical comment.
When the patient presented with chest discomfort, you note that a CT of the chest was done. Was any additional staging done at that time to evaluate the abdomen or the bones?
No, we have any shows that the bones was clear and the lung was clear, so we have only the tumor mass and lymph nodes on the axilla. That's all.
We might have thought of staging her at that point before her surgery, given the extent of disease on the CT of her chest. It's probably a little unclear whether these are metastases that developed after her chemotherapy or whether she may have had them at presentation, which might have altered how we handled this case in general.
Any other surgical perspectives on this? Or general perspectives? Okay, Charles, you want to ask your questions one at a time and we'll let the panel just discuss them. So the first question is the role of ascertaining biomarkers before and after treatment. Can you explain exactly what you mean to us?
We have a discussion inside our clinic, and we have different thoughts about these markers. Is it if we can use it, or we couldn't use it at all? And different physicians have different means. That is why we asked about this.
Anybody want to volunteer? Some comments? Brittany or Cesar, anybody?
Sorry?
No, I'm just asking my panel if they want to speak up.
I can comment a little bit. Let me just clarify. So that the patient was HER2 positive based on IHC?
Yeah.
Okay, so basically, I mean, if this patient at presentation did not have metastatic disease and just had locally advanced breast cancer, I think, here she would have been a candidate for neoadjuvant treatment with chemotherapy in a HER2 targeted therapy. And I think, if we had seen this patient, we probably would have recommended THP, which is Herceptin and pertuzumab, plus, Taxol or paclitaxel therapy. And that would have been given, over 12 weeks. So it would have been HP given every 3 weeks for 4 cycles, and then Taxol administered weekly for 12 weeks. And then depending on how she responded with that therapy, I think she probably would have gone to surgery, see if she had a disease response, and then probably received adjuvant chemotherapy after that with adriamycin and cyclophosphamide. And then the trastuzumab would be continued for 1 year of therapy because she's HER2 positive. I definitely think that there's a lot of value to the estrogen receptor, progesterone receptor, and HER2 receptor in early decision making for patients with a new diagnosis of breast cancer. And, I think this patient, would have benefited from HER2 targeted therapy, as I mentioned before, but also long-term with anti-estrogen therapy. And because she's post-menopausal, that would have been an aromatase inhibitor. And I think there's a little bit of data, and maybe Dr. Goss, you can talk about this, that perhaps letrozole is a little bit better in lobular carcinoma. Is that?
We're still waiting for that result.
Yeah. So I think
up at ASCO this year, 2016.
Okay. Yeah. So I think that there's some suggestion that maybe letrozole would be better, and so we kind of tend to give that for patients with lobular carcinoma.
Taras, a little bit. Some of the panel are a little bit confused by the case. So can you tell us what you think you would do as the perfect treatment for this patient? And by the way, I think it's misleading and difficult to interpret when you say HER2 plus. If you mean 1 plus on IHC, then it's HER2 negative. If you mean positive, then you mean positive. You don't just mean HER2 plus. That's a difficult statement to interpret for people, I think, a little bit. So if you just use a clearer statement of whether it's positive or negative, then we know. But what do you think should be done for this HER2 positive patient? Are you in favor of neoadjuvant chemotherapy with repeat of the biomarkers at definitive surgery? What exactly is your question about repeating biomarkers?
My question was about C15, C3 markers that we sometimes use. The second question about neoadjuvant chemotherapy was my second questions about these cases. So I thank you for the answer.
Okay, yeah. So do people want to comment on what is the question, Michelle?
I think he's asking about tumor antigens.
Serum tumor antigens, so antigen tests, tumor marker tests, not ERP or HER2, but he's referring to CA15 or CEA levels. So who still uses those? Do they have a role in this patient? Jack, do you want to comment about the biomarkers, those biomarkers?
Yeah, absolutely. Thank you, Paul. But first, just a very quick comment about the original HER2. Because of the lobular presentation and because of the vagary of immunochemistry in some cases, I think if it can be done, this should really be confirmed by DNA. With regard to tumor markers, I think there's been a blanket statement by ASCO and others that tumor markers should not be routinely used. However, I have found them intensely valuable in the right situation to help guide imaging and frequency in patients predominantly with bone disease. It can be very difficult to assess response. So I do believe that tumor markers can help to guide the frequency of medication changes going forward. I would, just as a final comment, say that I would probably take the opportunity to biopsy a first metastatic site to see whether the biology of that tumor is the same as the original.
Thank you, Jack. Does anybody else want to comment on the use of tumor markers? In this or any other patient with metastatic disease, do you still use them to evaluate burden of disease, response to treatment, or have they fallen by the wayside?
I can comment on what I do usually. I usually check a tumor marker, usually CA2729 is what we use here, or I may do 2729 and CEA just to have a second one, usually as a baseline in a patient with newly diagnosed metastatic disease, and then I don't usually follow it unless I'm not sure what is going on. So I usually use the clinical picture and imaging, and if they are discrepant, for example, if the patient is feeling better but the imaging looks a little bit worse, I may do a marker, and then I have a baseline to look back at. And if for some reason the marker is double what it used to be, that is pointing me in a certain direction. I don't routinely check them other than that, and I don't often have to do that. I think with patients with bone metastases, sometimes it can be helpful, and I do find it challenging when patients are referred to me and are used to getting regular tumor markers, because I tell them that I don't often know what to do with the result if they're being done and aren't really adding anything specific to the
Susan, do you want to comment on tumor markers? Thank you, Rasheen. Susan, Saja?
Yes, so I routinely use them for metastatic patients. So I normally do if I suspect new diagnosis of metastatic disease, I'll check them at baseline. If they're elevated, I would choose one of the markers and check it perhaps every 3 months. It tends to minimize the number of scans I need to do for patients, and that's a helpful thing. So I only use them in metastatic disease. The other times I will sometimes do it is if a patient really doesn't want to have scans, who I believe is high risk at the time of initial diagnosis. And then for that patient, you're doing the marker to say, your number's elevated. I really do think we should get a bone scan. I think we should do a CAT scan because your axilla is full. You've got a big primary tumor. So that's a little discordant with the NCCN recommendations, but I think you're trying to help the patient and use all the tools you've got.
Okay, can we just please have a surgical discussion about reconstructive surgery in this patient?
Well, if we're asking about reconstructive surgery now after mastectomy, chemotherapy, radiation, and the presence of known metastasis, I would say that I would try to dissuade the patient from reconstruction, because there is a great possibility they may have some complications because of the radiated field, and it's a lot to go through. I'd hate to see the patient off therapy for some reason, although letrozole could probably be continued through surgery. It might make it a little harder to evaluate for local recurrence with the reconstruction over the chest wall. So I wouldn't say that it's something that we would definitely prohibit the patient from having, but I would certainly try very, very hard to dissuade them in this case.
Any other surgical opinions? Jennifer, do you want to say something?
No, I just was thinking the same thing. This patient has a high risk of problems, complications postoperatively, and I think that she has enough going on, and I think I would work now first on getting better disease control of her metastatic problems.
Yes, by and large, can I ask you this question? Which of the two following parameters dissuades you from surgery more? The fact that she has stage 4 disease, or the fact that she's had previous radiation?
Probably her risk for complications, which would be the radiation.
Okay. So you still frequently perform reconstruction in patients with stage 4 disease?
Typically, I would say no. But, if somebody has well-controlled disease on an AI, I mean, certainly they could continue that through reconstruction. But I think that this lady has newly progressing and just a lot going on with her metastatic disease, and then she's high risk, so I think that this would not be a good idea.
Julia, do you want to comment?
I agree with Dr. Gettin about the timing of the reconstruction. I think the rapid progression of the disease really is the determining factor that I would not recommend reconstruction in her case, especially in the event that she has to go back on cytotoxic therapy that would interrupt her treatment.
Any comments, Alphonse?
No, just one thing on the way how we do it here. We usually do immediate reconstruction after mastectomy by putting either an expander or an implant. So we usually don't do the delayed reconstruction, or less often we do that.
Okay. Well, thank you very much, Taras. If you don't mind, we may move on to the case from Panama. And Joel Marino from Panama is going to present our third and final case this morning. So, Joel, can you hear us?
Yes.
Okay, Joel, we're ready with the slides. You can start presenting your case. Thank you.
Well, this case is about a 30-year-old woman. She has no comorbidity. but a family history characterized by 3 paternal aunts with breast cancer diagnosed between 45 and 50 years old. She's nulliparous with no other gynecobstetric history. By the 4th quarter of 2015, during a breast self-exam, she found a right breast lump. During her physical exam, a 2.5 centimeter lump between 11 and 12 o'clock radio of her right breast was detected with no axillary involvement. An ultrasound report a lesion of the same dimensions, BRAD5, and a core needle biopsy shows an invasive ductal carcinoma grade 2 triple negative by immunohistochemistry. Bone scan and hepatic ultrasound demonstrate no distant metastasis, no distant disease. It's a young woman with fertility desire, so she underwent an oocyte preservation, and the patient go through a genetic cancer test, an extended myriad MyRisk with 25 genes evaluated, and no clinical significant mutation was identified. 2 months later of her first evaluation, the surgeons underwent a lymph node biopsy with 2 nodes detected, and both of them was negative. A right breast cancer, stage 2A triple negative breast cancer, was diagnosed, and the proposed plan for this patient is neoadjuvant chemotherapy, AC for 4 cycles, followed by Taxol for 12 cycles, plus agonist of the gonadotropin release hormone for fertility preservation, followed by a conservative surgery, depending on the result of the neoadjuvant chemotherapy, more or less adjuvant radiation therapy. The patient is actually in the neoadjuvant phase. So we asked the panel, this patient with a strong family history, but with a negative gene test, do you consider neoadjuvant chemotherapy, or do you consider upfront?
Joel, can I just interrupt you? I'm sorry. We'll leave the questions up. I'd like any panelist just to have general comments about the case again, the way we did for the one before. So any comments about this case, any questions from the panel, any clarifications, please?
I'll make a comment about the sentinel node check 2 months after the fertility preservation. I think you're obviously doing the sentinel node in advance of neoadjuvant therapy to increase the chances that you'll find the sentinel node and not have false negative. There is a push now to use ultrasound evaluation of axillary lymph nodes and fine needle aspiration. So that might have been an option, and you could have considered that probably early before the oocyte preservation, because in the case of this patient, if she had positive axillary lymph nodes, waiting 2 months for treatment might have been something we would have counseled the patient about, thinking carefully if she really wanted to wait and do the oocyte preservation. Because at her age, she's probably likely to continue to be fertile after chemotherapy. Obviously, the medical oncologist can speak about that, but I probably just would have evaluated the lymph node differently.
Some other comments about her fertility preservation versus her neoadjuvant therapy, etc.?
You know, we have started with our endocrine group, our fertility group, and they've got a grant, and they really like to do the fertility preservation prior to any chemo. I don't know if it's just because of our grant or, you know, what it is, but as we're working with these premenopausal women, they really want to do that before the chemo. They really push us.
Brittany, do you want to give a comment on this?
Sorry. So, yeah, I kind of agree that maybe, you know, a complete nodal assessment should have been done before, like, making decision about fertility preservation, because she is young and she probably will regain her fertility after chemotherapy. I do think that like the 2-month delay seems a little bit long for the fertility preservation. I know it takes time, but I don't know if there are mechanisms to have that done a little bit quicker. I feel like we can usually do it like in like a 1-month time.
But because of her young age, both you and Michelle have raised the question about her being so young. Would you have not performed fertility preservation because she's so young?
No, I think if she was indeed node negative and that had been assessed early, I think fertility preservation definitely could have been done.
I'd like to point out that in a number of clinics, including the Dana-Farber and other places, I'm sure, around the country, have specialized clinics now, specialized groups that evaluate fertility preservation. And I'd like to point to the Latin American countries, a study that's going on through Cynthia Villarreal. She has set up a specific clinic and specific fertility preservation program, and she's interested in other people collaborating with her. So please communicate with us through Jessica if you want to join a group effort in evaluating this important endpoint and this important outcome in young patients. So that's just something for your interest. Other questions about this case? I'm sorry, I bumped in front of you. Please, Joel, feel free to ask your questions. I think, what about the negative gene test here that you're saying? That's your first question?
Yeah.
Go ahead. Sorry, one more comment, just generally.
Yeah, I mean, what is the results of her surgery? What was left? What's the amount of residual disease? And could you give a little bit more information about the radiation she received?
She's actually in the neoadjuvant chemotherapy phase.
She's still getting neoadjuvant. Okay, thank you. Any other general comments before discussion about the genetic testing and the strong family history with a negative gene test? Anybody want to speak to this topic?
So, Paul, I had a couple comments. So, in these young patients who truly want to maintain fertility, if it's possible, this patient kind of has a borderline tumor size. If it's going to take a while for them to have their oocyte preservation, there may be a role to do surgery first, and as they're recovering from their surgery and before adjuvant chemotherapy, at that point do their oocyte preservation. So this gal, 2.5 centimeter tumor, unknown nodal status, it's harder to know what the right answer is. And then I think the second question that was asked is, what do we do with this strong family history? I think we feel reassured that her gene testing is negative, but I'm not sure that we understand all of the genetic predisposition to breast cancer in Hispanic women. And I don't know that anyone on the panel has more information about that. Maybe we just didn't test for the right genes in this 25 gene panel.
So again, for the Latin American countries, I'll just say it again, Cynthia Villarreal in Monterrey in Mexico is collaborating with Dr. Weinstein, I think it is, from the City of Hope Hospital in the United States, and there are genetic mutations with strong family history being discovered. There's some Hispanic founder mutations that are unique, and because of this as a study, he's invited, and Cynthia invites anybody who wants to perform genetic testing on very young patients to collaborate with her and have a blood sample sent to the United States, and under research conditions for free, this patients can get this testing done, because I know this is frequently not a test that can be performed in South America. So just that comment. So then another surgical question is the role of sentinel lymph node biopsy. I thought you already answered that, Michelle.
Well, it says before or after pre-op systemic chemotherapy. So after chemotherapy, well, this patient's already had a sentinel node. It looks like removed, so there's no way to really go back and analyze the sentinel node at this time. But let's just say she'd had an ultrasound, they looked negative, and she got chemotherapy. We would do a sentinel node test during the time of the lumpectomy after systemic after chemotherapy. If she'd had positive FNA and then had chemotherapy, she could have a sentinel node out back. I think the studies are showing that we can increase the chances that we find a sentinel node, and that we reduce the false negative rates by using both the radioactive isotope and the dye after neoadjuvant therapy, and that we attempt to try to remove at least 2 sentinel lymph nodes at that point.
And what do you do with that result? Just clarifying about that result.
Well, the way we handle it right now, since there still is a little bit of controversy about how to handle a positive sentinel node after neoadjuvant therapy, we send that particular lymph node for a frozen section, and if it is negative, do not go on to do a lymph node dissection. If it's positive, we do a lymph node dissection. And usually we have tried to have a conversation with our radiotherapist, radiation oncologist, in advance to decide whether or not this is going to impact their decisions about radiation therapy.
So Julia, could you comment please from your perspective?
So the Sentinel trial has, and also the C1051, something like that, has given us some reassurance that sentinel biopsy is feasible after neoadjuvant chemotherapy with a acceptable low false negative rate. So at my institution, we often do the sentinel biopsy after completion of neoadjuvant chemotherapy. And I would suspect that this patient would yield also a negative sentinel node. It probably won't change her additional adjuvant treatment, such as radiation therapy, given the results of the sentinel node biopsy.
Thank you, Julia. Does anybody want to add to ovarian function suppression during neoadjuvant chemotherapy for the purpose of preserving fertility in these young patients? Does anybody have an opinion on this topic? Cesar?
Sure, yeah. So we do have some data looking at GnRH agonist in this setting, and that it can help with fertility preservation. In very young women, I think it's something you can certainly discuss, for fertility preservation during chemotherapy in general, whether it's neoadjuvant or adjuvant.
Brittany, you want to comment on that?
I agree. We do add that in for patients who are young.
And again, to preserve fertility with
Correct.
chemotherapy. Yeah. So does everybody agree with that? Jack and Susan, are you happy with that?
I would certainly add it in. I think it's worth comment to differentiate menstruation from fertility preservation, because a lot of the studies that have been published have really used that as a surrogate, having resuming menstrual cycles, which is not the same as fertility preservation. And the literature is very conflicted on whether this works. But that said, I am a favor of doing anything possible in this patient age. And of course, there's the additional benefit of amenorrhea in breast cancer outcomes. So I would include it.
Thank you, Jack. So in the last few minutes, if there are panelists I have failed to call on and you'd like to make some comments about any one of the 3 cases or some general comments, remember that these tumor boards are held with a view to having expert panelists like yourself be of assistance to doctors in developing low-middle income countries. So if you have any general points about the cases we've heard, can you speak up now, just in the last remaining few minutes, if anybody has a comment?
So I'll comment a little bit about surgery and how we're handling our lymph nodes. And I know that in some places, resources are limited, and you have to be prudent of your dollars. But we really don't do frozen sections on the lymph nodes anymore. So we will send them off for permanent, whether or not it's neoadjuvant or no upfront therapy, and then we take that case to our tumor board. And if it will change any adjuvant treatment, then we go on with surgery, because we know it's not prognostic, it's just telling you what has already happened. So instead of making a decision, in the operating room, but it saved us having to have frozen section available, and that's just something that we've changed based on the data, and that's how we do it here.
Michelle, do you concur with that? That more or less what's done here?
We only use we definitely have used much less frozen section for our sentinel nodes, and I believe only for the neoadjuvant, where if we found residual disease after they've completed all their therapy, we knew we definitely were going to do a lymph node dissection. That's when we do it, just to save the patient another operation, only in those situations.
Julia, what is your practice about frozen section on neoadjuvant nodes?
Our pathologists are very hesitant in doing frozen section because it wastes some of the lymph node tissue. Also, with neoadjuvant chemotherapy, there's some fibrosis involved in the treated lymph node, so it makes the interpretation of the histology more difficult. So our pathologists don't like to do them. So we often don't do frozen section and wait for the final pathology, and then we'll talk to the patient and let them aware that additional surgery may be necessary if the node is positive.
Okay, thank you. So Joel, I think those were very good questions and a little bit of controversy or differences in practice around those sentinel nodes after neoadjuvant chemotherapy. Yeah, make a comment. Have you still got a comment from Rosanna?
No, a question actually. Regarding the last case and considering this very young patient with such a strong family history and under the results of the Gepard-Sixto, would anybody consider giving her platinum as neoadjuvant therapy?
Any takers for platinum neoadjuvant therapy in this patient because of the strong family history, despite the negative test?
So I would just comment here, we are doing platinum therapy in the neoadjuvant setting, but in a clinical trial in patients that are BRCA negative.
And I think that's the same at MGH. We don't routinely give platinum, even neoadjuvant or adjuvant. But under clinical trial conditions, we definitely do. So the literature's on the fence still, and there will be more evidence forthcoming this year and next year about the use of platinums in this setting. Jack?
Oh, just one other quick option. In the U.S., there's a trial that's looking at neoadjuvant non-platinum containing chemotherapy and then stratifying by residual disease or not. So the patient who has a CR doesn't go on. A patient who doesn't gets offered further therapy that might include a platinum, and that might be an option if a trial were available.
Right. So any questions from our presenters, or are you all satisfied by the discussion? Well, I just want to thank everybody. Don't forget to take a picture of yourselves, even if you're alone. A quick selfie would be very valuable. Thank you. And of your room particularly, take a picture of your room. Thank you very much. And thank you all for joining the Tumor Board today. Thank you very much indeed. Bye now.